This is the Natural Wellness Academy, the CBD Cannabis certification for coaching. And we have a guest that we have been anticipating for quite some time. This is Dr. Jordan Tishler, and he is in the Boston area. He's a Harvard Medical grad and also on the staff at Harvard Medical School, and really one of the foremost authorities in cannabis medicine. He is also the president of the Association for Cannabis Specialists and also the founder of Inhale MD. He is a cannabis therapeutic practitioner employing Western medicine combined with cannabis. And from what I understand, your specialties have to do with stress management, insomnia, human sexuality. Anything else that I have missed?
Not at all, but I'm going to take a moment to kind of give people a little bit of a quick tour of my life. So whenever you're ready, maybe I should just launch into it.
Yeah, the one thing, I did want to ask you this question about the Association of Cannabis Specialists. Now, is this something that cannabis coaches could join, or would you recommend that we join something like this organization?
It's a really interesting question. The association does not discriminate against or have any particular people that it's, includes or excludes. I'm not being very eloquent at the moment. I apologize. The only part that is, specific is that we do ask whether a member is legally able to recommend or prescribe in their state. And if they are, then they have to agree to abide by a code of conduct that's sort of specific about, patient care and advocating for the patient and taking good care of them and that sort of thing. And then they can be listed in our directory of available specialists. But other than that, everybody is treated the same way in the association.
That's great, because that was something I had forgotten to put on my list. I'm hearing a little background noise, and I do seem to have everybody muted. So if for some reason you're not showing up on participants and you do have your mic open other than my mic and Dr. Tishler's, and I'm actually going to mute myself in a moment too. Actually, right now, I will let you take it from here.
All right, well, thank you. This has been a very warm welcome, and I appreciate that very much. I will say that I have a little bit of trepidation about giving this presentation today because I think that I'm going to say a few things that may fly in the face of things that you guys have heard. Everything that I'm going to tell you today is backed by the science, but some of it is not what's currently sort of commonly said, which is, of course, why I want to bring it to your attention. And I hope that none of you will take any of that in a personal fashion. And then, of course, when I'm done speaking, we can chat about it further. With all that being said, let me see if we can do the screen share thing that we've been trying to accomplish. Hopefully you guys are now seeing a slide that says medical cannabis, what is it good for? And let me just, say something about these slides. I'm going to tailor this as we go to our discussion for the day, but this is the same deck of slides that I use to talk to pretty much anybody, including my physician colleagues. It's not super scientific, but the point being is that, this is the material that I think we all need to know. Now, as promised, I'm going to give you the 2 cents on me. Yeah, I went to Harvard Medical School. I trained in internal medicine at one of the Harvard hospitals, big deal. What I think is much more interesting is how I got from there to doing what I do now. I spent 15 years as an emergency room physician at the VA. And as you know, the veterans have had a number of sort of chronic illnesses, PTSD, musculoskeletal issues as sort of general sets of issues. And on top of that, there's unfortunately a lot of substance related harm in that population. And so through my years there, I had seen, hundreds, if not thousands or tens of thousands of veterans whose lives were really harmed by substances. Alcohol being, numbers 1 through 9 on the top 10 list. And obviously alcohol is freely available. So, when we started to talk about cannabis as a potential therapeutic, I sort of had that light bulb moment and said, well, gee, I've seen all these guys that have been harmed by these sort of readily available substances, and I've never seen anybody sick from cannabis. So if it's really that non-toxic, maybe this use as medicine is legitimate. Let's see what data there are. And so, everybody was saying, oh, we can't take this seriously because we don't know anything about it. And I went to PubMed and I started pulling up the then like 20,000 studies and reading through them. And no, I didn't read all 20,000. And I came away after a few years of doing this kind of in the background with the sense that cannabis was very much legitimately a medicine, and there was plenty of data, but that you have to use it just like any other medication in a thoughtful, monitored way. And then as I was learning more about how cannabis is sort of being rolled out across the country, thanks to good old California, the model is very different. It's kind of like, the doctor just says, sure, get some weed, and then you go down the corner store and buy a lot of products and smoke a lot of weed. And that to me seems like a very bad model for getting good clinical outcomes. So I then started my practice in InhaleMD so that I could practice this kind of medicine, in the way that I would expect to be treated if I were the patient. With care and attention and advice and guidance and follow-up and all of those sorts of things. And then after that happened, I started looking around and saying, well, gee, why aren't there more people doing it kind of this way? And I started the Association of Cannabis Specialists really to sort of rally clinicians of all stripes, as we talked about, around this idea that we need to do better by our patients, specifically with cannabis medicine. And it's morphed now into an international organization that's focused on a lot of educational missions and some policy and regulation guidance for lawmakers, all aimed again at trying to make this system work better for our patients and their clinicians. So as I mentioned, I want to really try and leave time for us to have more of a discussion. So I'm going to try to whiz through this a little bit. And pardon me while I have a quick sip. When we start to think about what cannabis medicine is good for, there are a whole bunch of symptoms that we can treat. And in my view, many of these things are kind of no-brainers at this point. Pain is a hugely important thing. We know that across the United States, at least, pain is sort of the #1 presenting complaint where patients tell their PCPs, it's a big deal, and it isn't, what you are giving me isn't working very well. And to be honest, docs don't have that many choices, right? We've got Tylenol, which is one thing. We got non-steroidal anti-inflammatories, which is a class, but they're all kind of the same. That includes your ibuprofen and whatever. And those things work okay for some people and for some problems, but if they don't, or if the patient has some reason they can't take them, then you're kind of a little bit out of luck, because all that's left are opioids. And we know that opioids work okay, but they come with a whole lot of risk and baggage, right? Not only of death, but, horrible constipation and feeling out of control and sort of generally dysphoria and all those sorts of things. So we kind of have our hands tied. And
okay, we lost you for a second. We've got your sound back.
Yes, I'm afraid that we have to deal with the darned internet. Which
yeah,
is not
that's what my husband was going to watch too, and I said, you know what, that might take up too much bandwidth. So I was hoping that wasn't it, because he's not watching. But I think we're fine now. Go ahead.
All right. So I was saying, that when you bring cannabis into the mix, we finally get a whole new range of options, and that if you pit opioids against cannabis, as in which is better, what we find out is that neither of them are great. But cannabis for what we call mild to moderate pain is pretty much the same as opioids, with a whole lot less risk and baggage. The other thing that's important for us to know is that in studies looking at the use of cannabis along with opioids, we've been able to see somewhere between 40 and 80% reduction in the amount of opioid needed to get the same pain relief. And that's wonderful, because of course the risk associated with an opioid depends on how much you're taking. So if we can get you to the same place in terms of comfort, using less opioid and some cannabis, then that's a net win. Anxiety and depression is a huge topic that is often discussed in the public. And it's true that cannabis can be effective for anxiety and depression, but there's a big asterisk with that, which is to say that what we know is that it's not a very effective medication for anxiety and depression. So, if somebody has pretty mild symptoms, we can sometimes use cannabis kind of by itself as an antidepressant or an anti-anxiety. But most people are likely to need some combination of the cannabis with more conventional treatment. And if somebody comes in already on sort of a dose that's higher than kind of like the starting dose of a medicine like an SSRI, then cannabis isn't really a good substitute. However, as you all know, a lot of those conventional medications have side effects that turn people off. Whether it's sort of feeling like a zombie or sexual side effects. And cannabis can actually work well to sort of mitigate some of those side effects and actually make the whole thing work better. The other thing that's really important to know is that we know that if you use cannabis excessively, you actually can make the depression and anxiety worse. So we really have to pay a lot of attention to the dose and also to the timing. So that a small dose of cannabis given in the evening or before bed can be very effective. Whereas the sort of wake and bake model that we see in the community, we actually have really good evidence to suggest that can exacerbate the depression and anxiety, and it also can interfere with things like school and work performance and stuff like that. So that's sort of not the best model that's out there. Number 3 on the list is insomnia. I would say that this is another area where patients tell their doctors, we're not getting there. And I think that insomnia is probably the thing that cannabis treats best of all. And there are a couple different types of insomnia. Basically, it's sort of trouble getting to sleep versus trouble staying asleep versus all of the above. And the way in which we approach those problems with the cannabis depends on what kind of insomnia we have. So I'm going to come back to that in a little bit. You'll see on the slide, there's anorexia. I think it's really important to understand that anorexia in this context is the scientific word for poor appetite. We're not talking about anorexia nervosa, which is a psychological condition, and which actually cannabis can be counterproductive. But in terms of people who, for one reason or another, whether it's chemotherapy related or say a neurodegenerative disease like MS or ALS, who are losing weight, cannabis can be a very effective approach to stimulating appetite. And quite frankly, in terms of the sort of conventional medications, we don't have anything that works particularly well. So this is another win for cannabis.
Right. I just want to stop for one moment. Somebody has their, I keep going through the participants and muting everybody, but I'm not seeing whoever does have, if you're not muted, if you can kindly mute yourself, we're getting background noise. And this is so fascinating what we're hearing. So I'd like to, okay, that background noise is, well, it's still there.
I fear that it may in fact be my wife who you're hearing, who's
Oh,
in the
okay.
next office, who's, she's
Okay. That's fine. Okay, as long as we just don't want to interrupt you at all. So go ahead.
all good. So we were talking about nausea and vomiting. Interestingly, when you do another one of these kind of head-to-head studies of conventional medications versus cannabis, what we've learned is that the medicine that's called ondansetron, or also called Zofran, is actually more effective than cannabis for nausea and vomiting. On the other hand, it doesn't work for everybody. It doesn't always work completely. And I often say these things play nicely in the sandbox, right? There's no reason that if you're on Zofran, you can't also use cannabis. And so oftentimes the combination is the most effective. And you'll see now that sexual dysfunction is on this list. I'm not going to spend a lot of time on this because I can spend at least an hour just on that subject. But just briefly, one of the things that we know is that various sexual issues come up in both men and women throughout their lifetime with great frequency. And we also know that most people don't ever seek any care because, there's actually an interesting study that says Most people don't ask their doctors because they assume their doctors either don't know anything about it or don't want to talk about it. And the same study looked at how well the doctors were educated and willing to talk to it. Turned out the doctors were fine, but they weren't being asked. So anyhow, the point being is that when we think about sexual dysfunction for men, we've got some medicines that help with erectile dysfunction, but unlike what Hollywood would like lead us to believe, sexual dysfunction in men is much broader set of issues than just erectile dysfunction. And of course, for women, we've got no medicines at all. Cannabis, when used carefully, can be a very effective approach for a range of problems in both men and women regarding sexual performance, and both in the solo and partnered arena. This is one I really want to spend fairly little time on. We were just talking about symptoms specifically, but the question on this slide is really what kind of diseases can we address? And so we can break these down into neurologic issues, cancer-related issues, and autoimmune-related issues. I'm going to lump our neurologic and cancer together and just simply say, that there's a lot of promising research on cannabis or cannabinoids retarding the progression of some neurologic illnesses like ALS and various types of dementia, but it's all at the level of either the test tube or the mouse. And since none of us are either mice or test tubes, we have to really view this with a grain of salt. I had occasion several years ago to look up the fact of how many medicines work for mice in the laboratory and then fail for human beings. And it turns out to be an astounding 92%. So the fact that something looks good in a mouse doesn't really give us any reassurance that we can apply that to human beings. And the same thing is true on the cancer front. God only knows, we've all heard this cannabis cures cancer, Rick Simpson, blah, 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 except that none of that is actually backed by any science. We have some really good science on this that really looks very promising. A lot of it's being done in Israel by Debbie Mary, who's brilliant. But it's, again, at the level of the test tube. And so the road from test tube to human being is long. The autoimmune diseases I'm sort of leaving aside as its own category only because we have more evidence there in human beings. And in particular, this is related to Crohn's disease and the use of either cannabis for the symptom management, right? We talked about that. But when we're really talking about things that modify the course of the disease, there's growing evidence, largely that's been ignored, for the use of THCA. Now, you all know that THC and THCA are different chemicals, right? THCA, or acid, is the precursor of THC, but by itself, it's non-psychoactive, and it has an anti-inflammatory properties that are 10 to 20 times that of CBD, which means that it's vastly abundant, very safe, and very effective. And now we actually have some evidence to support that in the use in human beings for Crohn's disease, and also in my clinic where I use it, and I've seen some pretty nice results. I think I might skip through these pages on addiction and cognitive issues just on the assumption that you guys have sort of seen and grappled with this. Those slides are certainly more appropriately targeted at my very skeptical physician colleagues. And then let's talk a little bit about using cannabis in the therapeutic setting. And one of the things that's not on the slide, but I usually start with as the preface, is that, if you're listening to the cannabis industry, they want to talk about strains all day long, right? This strain is good for this and that strain is good for that. Where's the evidence? There isn't any evidence. There is not a single study that shows in a human being that a strain made any difference to their clinical outcome. Now, that's not to say that there aren't people out there who say, well, I really like cherry pie better than strawberry cough. Okay, that's a preference. But from my point of view, I want to know which one is going to work better on your back pain or your fill in the blank. And the answer is, as far as we can tell, there's no difference. right? So I tend to really ignore strains, with one caveat, which is that, we do understand through this concept, the entourage effect, that THC is the main medicine, but it is not the sole medicine. And that based on the fact that we've had drugs like Marinol available for 30 years and that people don't do super well on it, that in fact, we need some of those other chemicals besides the THC, which, I call them the helpers. I just lump them in a category. So if you have a strain that has a very high percentage of THC, then sort of by definition, you have a very low percentage of those helpers. So I tend to guide my patients towards strains that are, medium potency. And by that, I mean sort of 15 to 20%, so that hopefully we're getting more of those helpers in the mix. At some point, we will be better able to actually measure, which of those chemicals are present in various strains, but we don't really have that ability widely at this point. And furthermore, even if we do, we don't know what the right number is. So that's my spiel on strains. I think very much more important than strains are the routes of admission, right? Of administration rather. So how are we using it? And of course, the timing of that and the dose as well. So, I'm certainly not going to tell you anything that you don't know in terms of the options, but here's what I can tell you about how I think of them. Number one, I don't generally recommend smoking because, well, smoke is full of all kinds of toxins and garbage that, we have some data that says it's not as dangerous as tobacco, but I don't know that that's a good reason to just go off and smoke, right? I mean, if smoking were the only option, then we would deal with that, but it's not the only option, so we can avoid it. Why do we want any of that? Well, here's the point. And again, this is nothing new to you guys. We know that when you take something by inhalation, it's rapid onset, right? 10 to 15 minutes and it's doing its job. And then it also wears off relatively quickly, meaning sort of 3 or 4 hours, right? So for certain kinds of conditions, this is the best approach. And I generally lump that into things that are sort of acute or episodic. And a great example is kind of like a migraine headache, right? That we know from the non-cannabis literature that the best way to treat a migraine headache is to get after it right away. Don't let it develop into some horrible thing. And so, taking, say, an edible that's going to kick in a long time is just not the right answer. So, getting in there with the inhalation at the first signs of this headache is a better way to treat it. On the other hand, if the headache goes away after our treatment, we would like the medicine to go away too, so that we could get back to whatever it was that we were planning to do for the day. So that's why we would think inhalation in the first place. And so if we're not smoking, hopefully you can see my pointer here. Our options are the little oil pen people call vapes. And then we've got above it, we've got this sort of flower vaporizer. If any of you guys have encountered anything I've said or written before, you know that I very much dislike these oil pens. They're dumb devices. They're basically a battery and a heating element, and they don't vaporize in any true sense. What they do is they combust, right? And if we combust an oil, we get carcinogens just like we were combusting anything else. And so again, I don't think technologically this is ready for prime time. It's not the oil that's a problem in my mind. It's how we treat the oil. And somehow at this point, nobody has stepped up to build a better oil pen. So the option that is better are these flower vaporizers. And the reason that they're better is because they actually have a little computer brain in them that is measuring the temperature at the bowl, right? And making sure that it gets to the right temperature and then stays there, right? So the right temperature, it turns out, is 350 degrees. I always say, just like we're baking cookies, right? We need a machine that can get to 350, but we also need a machine that will keep it at 350 and not let that wander higher. Because once you get up to 400 degrees, we start to make benzene, which is carcinogenic, and the list just kind of mushrooms after we pass that 400-degree threshold. So this is my current approach for inhalation. Now, the internet would lead us to believe that if you don't want to smoke, then, edibles, usually in the form of cupcakes and brownies, would be your other alternative. And I think that that's exactly the wrong way to think of it. We all know that while the inhalation is quick and relatively short, that the edibles are slow to work. They're even a little unpredictable and variable, but once they do kick in, they last more like 8 to 12 hours. So we can think of the inhalation as our immediate release medicine and the edibles as our extended release medicine. And that makes them much more appropriate for different kinds of problems. Problems that are constant in nature, say arthritis in the back or arthritis in the knee and that sort of thing. So using that at regular intervals, say breakfast and dinner time, can get us sort of continuous coverage of this pain. And the other thing that's important to know is that we know that from the pain management literature, that using something fast acting on a chronic problem tends to be can backfire, because you kind of get this yo-yo scenario where it's like you take the medicine and you feel better, but then it wears off and you feel worse, and you actually learn to anticipate feeling worse. And so you get this thing where you're bouncing around and it's actually a bad situation. Whereas if we use the extended release versions and we can get that nice steady level, then people respond better and their pain is better controlled. Let's just take a moment to have a holistic thought and say, many of our patients are overweight, they're diabetic, et cetera. So we do not want to be telling people go take, a brownie twice a day, right? That would be an extra 500 calories in their diet that they didn't need in the first place. So I tend to gravitate towards little gummies. They're very effective in terms of their absorption. And you're looking at 20 calories, right? So and the other thing about the gummies that I should mention is that they're nice because they're a single unit, right? If a gummy has 5 milligrams in it, there's sort of no muss and fuss there, right? Either you took the gummy or you didn't take the gummy. It's not like, oh, well, how many drops was that on the spoon? Or, I've got this chocolate bar and it has 100 milligrams in it. How much is each square worth? And all those kind of mental mathematics. So I tend to gravitate towards the low dose gummies. Now, tinctures. Tinctures are insanely popular. I don't really understand it. I think they taste bad, they're messy, and they really can mess up people's dosing. One of the things that again gets said is you're supposed to put the tincture under your tongue. And this is based on science that was done by GW Pharmaceuticals, but their products bear nothing in common with your garden variety dispensary tincture. And so what we do know is that when you put that garden variety tincture under your tongue and hold it there, nothing happens. You may feel like something happens, but if we actually measure your blood cannabis levels, there's nothing in there. What happens is when you swallow it, it's absorbed like anything else through the gut, although the absorption of tincture is generally about half as good as those edibles. So again, if there's no reason not to, I gravitate towards the edibles first. And in fact, when I do need to use a tincture, say I need to get a very, very low dose, or somebody has like a feeding tube or something like that, then I say, don't put it, don't drop it into your mouth, right? You have no idea how many drops you're really getting. Drop it onto a spoon and take it like a cough syrup, meaning in the mouth, down the hatch, chase it with something because it tastes nasty. But I think that that's a better way to make sure that we're getting the right dose and a consistent dose. The other product that's out there that people love is various topical agents, cannabis salves and lotions and patches and stuff like that. And again, this is an area where there's a conflict between the products that we have and the experience on the pharmaceutical side. There's a lot of science that goes into making a pharmaceutical patch that just doesn't exist on any of these cannabis products. And what we know is that cannabis applied to the skin will not penetrate the skin on its own. So again, when you go to the dispensary and you get one of these products and rub it on, we're really expecting placebo response, because we know that the cannabis is not going through the skin and it's certainly not penetrating into, say, your knee, which, from a biological point of view is miles away from the surface. So I tend to avoid those things entirely. Dosing. This is something that the cannabis industry has really not grappled with just yet. But it is important to understand how doses work, right? And this is sort of very typical curve here. It's not specific to cannabis. This is true with all medications. You start with a low dose and you work your way up. And at some point you get up here to the sweet spot where you're getting the maximum benefit with the minimum of side effects, right? But what we know is that if you push the dose beyond that sweet spot, you don't get more benefit, you just get more side effects. And with cannabis, the intoxication is really the primary side effect. And obviously dry mouth, and there are a whole bunch of others, but the one that really can be surprising and show-stopping for our patients is the intoxication. And so once you get past a certain level, we're not getting better benefit, we're just getting more of that, the negative stuff. And the thing that I think surprises many people in this industry is that patients do extraordinarily well on what is considered minuscule doses by people who are more seasoned users. So my patients really average about 10, maybe 15, but really around 10 milligrams. Some are much lower, sort of in the 5 milligram range, and a small handful are up in the 20 range. But generally speaking, on average, 10 milligrams. And so that kind of specificity, I think, is really important for getting the best benefit and also repeatable, reliable benefit. And I always say we don't want to send grandma home to do bong rips. I've talked about that. Certification. This is another thing we've inherited from our dear old friends in California. In this industry, there's such a focus on getting your card that I think it very much undermines what it is that really can be brought to the table here. When you go to see your PCP, if you think that maybe your blood pressure is high, you generally don't go in and say, Doc, I want you to write a prescription for lisinopril. You say, Doc, I'm concerned about X, Y, and Z, maybe my blood pressure. What do you think? And then your doc, does some readings and talks to you, and hopefully talks to you. And then they say, yeah, I think your blood pressure is elevated. So here are some options. Here's what we should do. And so my point is that the prescription for the medicine is sort of the end result of this discussion, not the beginning of the discussion. And I think that the focus on getting your card, or worse yet, people call it their license, like it's a dog license or something, really just puts the emphasis on, access to the drug, not on access to care. So I think that it's really important, and we've got scads of studies at this point showing that patients do better with the guidance of their clinician. And so we need to, and this is again why the ACS was invented, to really put that emphasis back on taking proper care of people. It's complicated, I think, in large measure, because there are companies and dispensaries out there that are sort of actively using the sort of misinformation that's on the internet, and maybe even contributing to that misinformation, as a way to sell more weed. And I would say that that's a taking advantage of patients, right? I mean, patients come in and they're feeling poorly, and they're uncertain of what to expect and all of that sort of thing. They're in a vulnerable position and shouldn't be fed a lot of BS as a matter of trying to, sell them product. Now, I would argue that it's really upon the clinician to have allayed those fears and to have given them specific instructions. But we also know that even with the best of interactions with the clinician, once they walk into that dispensary, there's a certain interaction there that I think we can improve upon. So I talked to you guys a lot about the Association of Cannabis Specialists. If any of you guys are interested in checking it out, maybe even joining, cannabis-specialist.org, that's where you would go. And there's a growing amount of educational stuff there, some of which is freely available to the public, and the majority, of course, is reserved for members. So I would just, urge you to take a look at that. And then this is my last slide. It's got some references if you want to follow the bit.ly link. And here's how to reach me. That's pretty much it right there. What I will say is that I'm really good at answering email. So if you have questions that we don't get to today, feel free to hit me up at doc@inhalemd.com. And I have no idea how we're doing on time. So let me stop the share. Oh,
we have plenty of time. And I do have some questions, and we'll go through them. And then if there is time still, we will open up for more questions.